past their gland. Now sometimes you'll have a gland in which the secretory units, some of them look tubular and some of them look alveolar. So they'll refer to that as tubulo-alveolar. You'll see that a lot. Okay. Down here are compound glands. These are compound because the duct system itself is branching, not just the secretory units. So compound tubular, compound alveolar. Okay. If the duct system is branched, that means that the secretory unit is going to be branching also. Now we said you can also categorize exocrine glands based upon method of secretion. Again, we're talking about exocrine glands. So we have three types: merocrine, apocrine, and holocrine. A merocrine gland is one in which the secretions are released via exocytosis. Let's go over exocytosis. Let's say this is a cell that's producing secretions. Here's the nucleus. What happens is the secretions get packaged into a little vesicle, like this. Okay? And that vesicle moves to the cell membrane, to the surface of the cell like this. Okay? And then when it reaches the cell membrane, the secretions are released across the cell membrane. There's a little opening that occurs. That's called exocytosis. None of the cell is lost during the process. None of the cell it's the exact opposite of endocytosis. With apocrine glands, okay, by the way, they're showing here salivary glands or merocrine. They release secretions through exocytosis. Mammary glands, on the other hand, are apocrine glands. What this means is that the secretions are carried to the apical portion of the cell, and the apical portion of the cell breaks off and becomes the secretion. So part of the cell is lost during the production of the secretion. So the apical portion is lost, hence the term apocrine gland. Holocrine glands are ones in which the entire cell breaks down. The entire cell containing secretions breaks down and becomes the secretion. Okay. An example would be the sebaceous glands of the skin, or the glands that produce cerumen within the ear. Those are holocrine glands. Now, let's talk about the nature of secretions. Some cells produce mucus secretions. Mucus secretions tend to be thick and rich in mucin or mucus, and that's a glycoprotein. Okay, it's used to lubricate. Mucus glands this is a cross-section for a secretory unit. And for reference, let's go back for a second. Let's say I'm creating a slide and I cut through part of the secretory unit here. This is an alveolar gland. Well, in cross-section, it's going to look more like this. Cells lining the lumen. There's the lumen, the white portion in the middle. The surrounding cells are what we see here. Now, with mucus glands, the nucleus tends to be rounder and more centrally located. I'm sorry. The nucleus tends to be flatter and push down along the basal surface of the cell. Okay. Furthermore, mucus glands tend to be eosinophilic. Do you remember what eosinophilic means? Well, when we stain tissue, the classic stain is called an H&E stain. And H&E stands for homoxylin and eosin. Okay. With mucus glands, the mucin or the mucus attracts the eosin component of the stain. Substances that are eosinophilic stain a very light pink in color. So these glands are very light staining and they have a basally oriented nucleus. Now, let's differentiate that from Cirrus glands. If we were to cut through that secretory unit and this happened to be a Cirrus gland or Cirrus secreting gland, Cirrus glands produce more watery secretions that typically contain enzymes. For Cirrus glands, the nucleus is more centrally located, rounder, okay, and the cells themselves are darker staining. Okay. They pick up the amoxicillin. So they typically stain a darker purplish color. So under the microscope on the light microscopy, we can differentiate cirrus from mucus. And again, cirrus and mucus refer to the nature of the secretion. Mucus is a thick glycoprotein that lubricates, whereas cirrus secretions are more aqueous or watery, containing enzymes. So for instance, the glands that produce digestive enzymes, because those secretions contain enzymes dissolved in water, those are cirrus glands. They stain darker. All right. This is an interesting organ. This is actually the pancreas. And it's interesting because it contains both endocrine glands and exocrine. Okay. These cells here that are arranged in cords make up part of the endocrine pancreas. These are referred to, these little clusters of cells are referred to as islets of Langerhans. These are the cells within the pancreas that produce insulin, that produce glucagon, and a couple of other hormones. When these produce their hormones or secretions, they're released directly into tiny blood vessels that are interspersed with these cells. In other words, insulin and glucagon are not carried by any ducts. Now, these islets of Langerhans are surrounded by exocrine glands. These are clusters of serous-secreting alveolar units. Okay. And notice that these are serous secretions. In other words, here's a little secretory unit here, similar to what we've drawn here. Okay, notice that the nuclei are nice and round, and that the cytoplasm of these cells is darker stained, kind of a darker purple. They oftentimes you can see little granules that are called lysozymes inside the cell. These are serous secretions, part of the exocrine pancreas. The exocrine component of the pancreas produces digestive enzymes that are carried by a duct. Initially, these secretions enter into tiny ducts, but the anastomose, ultimately giving rise to the pancreatic duct, that's going to carry these secretions into the duodenum, so that these digestive enzymes can break down nutrients within the diet. Everybody follow that? All right. Now, different types of epithelium have different regenerative capacities. That means the capacity to undergo cell division and replace cells that are lost. Many types of epithelium, for instance, like that of the epidermis, are considered labile epithelium. That means they have a higher regenerative capacity. Okay? Most epithelial tissues are labile. They have a high regenerative capacity, and the cells continuously undergo mitosis, okay, and replace cells that are lost. Okay, so typically you have stem cells at the base of the epithelium. For instance, in the epidermis, these cells are located within the stratum basale, touching the basement membrane. And those cells are continually undergoing mitosis, and the daughter cells then move up toward the surface to replace cells that are lost or shed. That's a labile epithelium. A stable epithelium is one in which the cells don't ordinarily divide, but are capable of dividing if tissue is damaged. For instance, within the liver, hepatocytes are not active mitotically. But if part of the liver is lost, let's say someone has surgery, you remove most of the liver, well, there's a limited capacity to replace those cells that are lost. That's referred to as a stable epithelium. And a few epithelial tissues are permanent, non-renewable. For instance, the cells that make up the core of the lens of the eye, okay, they're permanent. If you lose some of those cells, they don't get replaced. Epithelial cells are capable of adaptive change. In other words, change in response to the environment. So these cells may adapt to alterations in their environment. What are some types of adaptive changes? Atrophy, hypertrophy, hyperplasia, metaplasia, and dysplasia. Let's talk about each in turn. Atrophy means shrinkage. Shrinkage in the size of the cell by loss of cell substance. Now, when you have a sufficient number of cells that undergo atrophy, then the entire tissue or organ becomes atrophied. Okay? Or the term is the adjective is atrophic. So what kind of changes in the environment can trigger atrophy? Well, increased workload. The other day, in AG1, I showed a picture of Arnold Schwarzenegger. Y'all know who that is? Okay. And the picture was when he won his title of Mr. Universe. They had these huge bulging muscles. Now, I recently saw a picture of him on the beach in California, okay, without a shirt on. He's not the same person. Those huge bulging muscles no longer exist. Okay? Why? Because he hasn't continued to work out like he used to when he was young. So those muscles have been exposed to decreased workload. So what happens to the cells? They shrink, they atrophy. If there's a loss of innervation, let's suppose someone has a stroke and muscles on one side of the body lose innervation. What do? They shrink. Other reasons for atrophy is a loss of blood supply, inadequate nutrition, loss of endocrine stimulation. Yes, some cells require hormonal stimulation in order for maintenance. If they lose that hormonal stimulation, they atrophy or shrink. These are two different brains. The brain on the right is normal. The brain on the left is when the patient exhibits physiologic atrophy. That means atrophy associated with aging. You can see how the gyri become more prominent because the sulci, the grooves, have become more prominent. The grooves are more prominent because the gyri, the cells of the gyri have shrunk. What happens is as we age is that all of our blood vessels, our cerebral blood vessels, develop atherosclerosis. So as a result, there is decreased blood flow as a result of the narrowing of the blood vessels. And through time, the tissue shrinks or atrophies. Hypertrophy is just the opposite. Hypertrophy refers to an increase in the size of the cells, and if enough cells hypertrophy, the entire organ hypertrophies. And this may be caused by an increase in functional demand. Earlier I gave the reference to weightlifting. Okay? That's an increase in functional demand. The cells, the muscle cells, increase in size. Or in some cases from increased hormonal stimulation. This can be both a physiologic condition or it can be the result of a pathologic condition. For example, we'll come back to this. Hyperplasia refers to an increase in the number of cells, in the number of cells in a tissue or organ. Right? That again, if enough cells undergo hyperplasia, the organ increases in size. As I mentioned with hypertrophy, it can be physiologic or pathologic. An example of physiologic hyperplasia is enlargement of the breast at puberty or during pregnancy. There's increased hormonal stimulation. Okay? Pathological is the excessive hormonal stimulation of target cells. For example, benign prostatic hypertrophy that occurs in males when prostate enlarges. That's the result of excessive hormonal stimulation that causes both hypertrophy and hyperplasia of the cells. So the prostate enlarges. It can begin to compress the urethra that travels through it. Metaplasia. Reversible. This is a key word. It's a reversible change in which one adult type of epithelium is replaced by another type of epithelium. One better suited for the environmental changes that are occurring within that tissue. So this is an adaptive substitution of cells, more sensitive to stress, by other cells better capable of handling that adverse stress. Okay, so under situations of some type of stress, one epithelial type is replaced by another that's better equipped. Okay. So under adverse environmental conditions, undifferentiated stem cells are stimulated to differentiate along a different or divergent line. I'm going to give an example of that. Well, here's one. In smokers, okay, typically the airways are lined by a pseudostratified columnar epithelium. But cigarette smoke is a noxious type of chemical that creates an adverse environment within the airways. And under those conditions, those pseudostratified cells can undergo metaplasia into a stratified squamous type epithelium. Okay? In fact, that's one characteristic of chronic bronchitis. If you do biopsies of patients who have chronic bronchitis, you will see areas of squamous metaplasia where there should be a pseudostratified columnar epithelium. This condition is reversible. If someone stops smoking, that squamous epithelium may revert back to pseudostratified. If they don't stop smoking, these metaplastic cells can undergo further changes and become what's called dysplastic, which is one step to becoming malignant. This slide is from a cervical biopsy. This is a part of the uterine cervix that typically has a simple columnar epithelium. And you can see that in this region of the cervix, that simple columnar epithelium has transitioned into more of a stratified squamous epithelium. So this would be an example of squamous metaplasia. For instance, it may be an infection that triggered this change. Typically, stratified squamous is a more protective type of epithelium. Okay, it's able to sustain damage easier because it's got a high regenerative capacity. So cells that are damaged would replace more rapidly.
Dr. Penner,
Yes.
I have a question about that. I know you're not an OBGYN, but about a year ago, they found non-cancerous cells on the cervix. Would that be something similar to that situation? Are the squamous?
Non-squamous cells can certainly be normal cells. I don't know what that, I would need more details.
Okay.
This is a section from a duct of the salivary glands. Okay. This is a normal salivary gland duct. This is a larger duct. I know that because it's got a stratified columnar epithelium. It's got 2 layers of cells, so it's stratified. Here's the basal layer. The more superficial layer of cells look columnar. So remember, you can find stratified columnar epithelium in very large ducts. So this is the large duct of the salivary gland. Now, this next is from a picture of a patient who's got a stone in one of their salivary glands. It causes irritation and inflammation. In that situation, this stratified columnar epithelium has transitioned into a stratified squamous. So again, that's an example of metaplasia. Okay. Here's columnar metaplasia within the esophagus. To the right is a normal esophagus with a stratified squamous epithelium. This is non-keratinized. You can see nuclei extending all the way up to the surface. But as you move along the esophagus, now you see a columnar epithelium in which you start to see formation of these glands. In fact, if you didn't notice it was the esophagus, if you're simply looking at this section of the tissue, this resembles the stomach. It resembles gastric mucosa or gastric epithelium. There's a term for this type of metaplasia that occurs in the esophagus. It's called Barents Esophagus. And it occurs in patients who have chronic reflux. In other words, when acid continues to reflux into the distal esophagus, that irritation triggers this columnar metaplasia, so that the mucosa, the surface of the esophagus, resembles more the surface of the stomach, which can handle acidic conditions. And again, this type of metaplasia, if someone has Barrett's esophagus, then they have to be scoped every 6 months. They have to be treated and scoped because there's the risk that this type of metaplasia can evolve into dysplastic tissue. Dysplastic is abnormal tissue that can lead to malignancy. Again, metaplasia is reversible. So if this person undergoes surgery for reflux, you tighten that sphincter, and they no longer reflux, then this can revert back to this. At this stage, it's still reversible. Okay? But I like to think of metaplasia as an initial step toward malignancy. That brings us to dysplasia. Dysplasia is abnormal epithelium, where you see irregular, atypical proliferative changes in response to chronic irritation or inflammation. Okay? The cells lose their normal orientation to each other. Okay? Instead of seeing normal architecture, the cells become more disorganized. The cells become more pleomorphic. That means the size and shape of cells becomes more variable. The nucleus also can change size and shape. Oftentimes the nucleus becomes smaller and darker. Okay? And the staining characteristics of the cells can change with dysplasia. So the idea is that the tissue becomes more abnormal and disorganized. Okay? But with dysplastic changes, all the cells remain located above the basement membrane of the basal lamina. They don't break through the basal lamina. Now, if those cells that are exhibiting disorganized growth begin to break through the basement membrane into the underlying tissue, we call that a neoplasia or malignancy. Okay? So this is the next step toward malignancy, but it's still potentially reversible. This is, again, a cervical biopsy. To the left here is normal tissue, okay, but it merges with this plastic tissue, okay, on the right, where the cells are more disorganized and the nuclei are darker. Okay. Some nuclei are big, some of them are smaller. The cells vary more in size and shape. This is even a worse condition. This is the same thing, cervical dysplasia, but now the cells are becoming even more disorganized. But notice that they don't break through the basement membrane. So the cells appear even more pleomorphic, and the nuclei are what's called hyperchromatic. Hyperchromatic means they're darker. Okay. So dysplasia is yet another step toward malignancy. If we start seeing these cells break through the basement membrane and extending into the underlying lamina propria, we say this person's got a malignancy, a neoplasia. Yeah, so the next step is neoplasia. Dysplasia can progress. So you can think along these evolutionary lines. Metaplasia, if it doesn't revert, it can lead to dysplastic changes, which if it doesn't revert and continues to progress, can lead to neoplasia. And a neoplasm is a malignancy. So that was very important. Neoplasms are tumors. Just as you see abnormal growth of cells, rapid disorganized growth, they form masses, tumors, swellings. Okay, we'll call that a neoplasm. Benign neoplasms versus malignant. Benign neoplasms don't metastasize, okay, meaning they don't enter into the bloodstream or lymphatics and spread to distant parts of the body. Benign neoplasms remain localized. It doesn't mean that they can't kill you, it's just that they don't enter into the bloodstream and spread to different parts. For example, you can have a benign pituitary adenoma in your brain, but even though it doesn't spread, let's say, to the liver, as it grows, it can compress normal brain tissue and kill you. But it's considered a benign neoplasm. Malignant neoplasms, though, not only invade local tissue, not only spread locally, but they can enter into blood vessels or lymphatics and metastasize to other parts of the body. Now, if that benign tumor, if that benign neoplasm is derived from epithelial tissue, if it's glandular epithelium, we call it an adenoma. If it's surface epithelium, we call that benign neoplasm a papilloma. An example, a wart is a benign growth of surface epithelium. Well, a wart is really called a papilloma. It's an abnormal growth, but it's not going to metastasize. It's benign. Now, if you have a malignant neoplasm that arises from epithelial tissue, you call it a carcinoma. Okay? And the term carcinoma is really relates to a tumor-derived, malignant tumor derived from surface epithelium. If it's derived from glandular epithelium, we put that word adenoma in it, adenocarcinoma. So an adenocarcinoma is derived from glandular epithelium. That glandular epithelium has one growth. It's become disorganized. It's growing more rapidly. And because it's malignant, it can metastasize. All right, did everyone follow all that? Yeah, it's a heavy dose of reality. All right, what we're going to do now is I want you to pull out some microscopes. Take a microscope of money. And what I want you to do is to try to use the same one every glass. So find a microscope you're comfortable with, make sure it works well. The lens is clean. Feel good about it. Because then I'll ask you to put it back in the same place and use the same microscope each day.